megacolon secondary to Chagas disease will most likely show A. Fibrosis of the lamina propria of the mucosa. B. Attenuation of the muscularis propria. Letter C. Absence of ganglion cells in the submucosa and muscularis. Letter D. Presence of foamy macrophage in the lamina propria. Megacolon acquired because of Chagas. Is it fibrosis, attenuation of the muscularis propria? B. Absence of ganglion cells in C, and D. Presence of foamy macrophage in the lamina propria. Okay, so megacolon can be acquired and congenital, no? The absence of the mesenteric ganglion cells. Okay, so you have the acquired part of the acquired is the Chagas, which damages the ganglion cells. So letter C is the correct answer. Next, please. The most feared complication of ulcerative colitis is toxic megacolon, development of carcinoma, B, C, perforation with peritonitis, and D, venous thrombosis.
Joke lang. Mali yung sagot ko. Ako ang katatakutan ko dyan.
Feared complication.
Ang katatakutan ko.
That's the
Ano?
When you say you're feared, you're scared.
Carcinoma. Diba? Toxic. Ang toxic na ako yun.
So the correct answer actually is development of carcinoma.
Bakit
Okay, so
perforation peritonitis?
ulcerative colitis is part of the inflammatory bowel disease. A, B, and D are complications. You don't expect to see perforation of ulcerative colitis because the lesion only involves the mucosa. The inflammation does not extend into the muscle. So therefore, the perforation is a very rare event in ulcerative colitis. You do have toxic megacolon, you do have venous thrombosis, but the most feared complication is the development of cancer in this because ulcerative colitis can predispose to dysplasia, which can predispose to carcinoma. So correct answer is letter B. Next. Okay, so this is my question now. So the depicted lesion is characterized by number 1, this is the lesion, columnar metaplasia of the esophageal squamous epithelium. Letter B, presence of longitudinal mucosal tears and ulceration. Letter C, atypical glandular cells. Letter D, lower esophageal sphincter spasm.
May tear na siya, no?
So this is the lesion.
Most.
So what is this? If you look at it, this one is a tear, no? Look at the normal. This one is a tear or a laceration. It's longitudinal along the long axis of the esophagus, usually located in the distal portion associated with alcoholic binge, vomiting. So you have hemorrhage usually, so that's why you have this blood. So it's a longitudinal tear, which we also call Mallory-Weiss syndrome. So the Mallory-Weiss syndrome is characterized by the presence of these longitudinal tears of the mucosa with ulceration. Columnar metaplasia of the esophagus is what? What? Columnar metaplasia is Barrett's, no? And atypical glandular cells usually seen in carcinoma or dysplasia, and lower esophageal sphincter spasm is associated with what condition? Achalasia, right? They have problem with the LES, lower esophageal sphincter, achalasia. Next, very good. Next question, number 12. The most common cause of this lesion is it alcoholic cirrhosis? B, Barrett's esophagus? D, extrahepatic portal vein obstruction? Or esophagitis? This. So what is the most common cause of this animal? Before you can make a an educated guess, you have to identify who expressed the lesion, right? So what is this? The correct answer is actually A, alcoholic. So what is this? This is an esophageal varus. So varus, you have this large worm-like, not a snake, worm-like dilatation of vessels. You see this squamous lining, you see this thin-walled ectatic, and this is a vesigram with the dilatation. So this is a varus, okay, esophageal varus. And what does esophageal varus, how does it develop? When there is portal hypertension, okay? When there is portal hypertension, there is portosystemic shunting and formation of collateral circulation. And the collateral circulation are the esophageal varices. So this is usually related with cirrhosis, be it alcoholic, post-necrotic, etc. Cirrhosis. Barrett's
Ayaw mo
esophagus
ba?
is related
Nangalay
to
na ako eh.
reflux, isn't it? Chronic gastroesophageal reflux, wherein you see columnar metaplasia, which you don't see here. That's the squamous lining. The hepatic portal vein obstruction is Buchiari syndrome. This is which is basically what we see is the esophagus here. Esophagitis, that can be a differential diagnosis, but it will not explain the worm-like and the dilated vessels with just plain esophagitis. So the best answer here is alcoholic cirrhosis. This diagnosis here is a Barrett esophageal varices. Number 13. Next number 13. A 68-year-old female has suffered from gastrointestinal reflux disease with Barrett's esophagus. Can develop this type of esophageal malignancy.
Squamous cell.
Squamous cell? Is it leiomyosarc? Is it adenocarcinoma?
Uy,
Or
pa-input
lymphoma?
ako, Lin.
The question is,
Lin,
what cancer
one.
can develop
Thank you.
from a Barrett's esophagus?
Squamous cell.
The correct answer is adeno-CA. That's logical. If you only know the underlying pathogenesis, you can make an educated guess. By definition, Barrett's is metaplasia, right? From the normal squamous to columnar intestinal type. So if it's a gland, what is the malignant portion of the gland? Adenocarcinoma. If it is a squamous, then it should be squamous cell carcinoma. Since this is a metaplastic change in the Barrett's esophagus and the metaplasia is a glandular metaplasia, then we expect that which we see here, these mass are adenocarcinoma. So the correct answer here is letter C, adenocarcinoma. The point is, the cancer that develops out of Barrett's most often is adenocarcinoma. Put that in your head. Okay? Next. 14. Number 14. A young patient had severe episode of dysphagia with aspiration of previously ingested food and difficulty of swallowing. The depicted lesion is shown, which is consistent with the diagnosis of letter A, Barrett's, B, Meckel's diverticulum, C, achalasia, letter D, Hirschsprung's. Okay, very good. The majority of you answered achalasia. Okay, so you have a young patient. So most likely this is going to be congenital. And the symptoms are upper, dysphagia. So it looks like an esophagus problem, isn't it? With aspiration of previously ingested food, that there's a problem with swallowing. So you can easily remove Hirschsprung because Hirschsprung is a disease of the colon. So, layo naman nun, ano? And then you can also, Meckel's diverticulum can easily be removed because this is located in the ileocolic area, ileum, right? So we're left with just two processes in the esophagus, which is Barrett's and achalasia. Now, achalasia is a problem with lower esophageal sphincter that is spastic and then it obstructs, which we see here. And that distal to the obstruction spasm is a dilated portion of the esophagus. So this is the reason why you have this dysphagia and aperistalsis, because there's a motor problem with the sphincter. So the correct answer here is achalasia. Again, Barrett's is squamocolumnar metaplasia. Next slide. Number 15, which is an ulceration occurring in the stomach in a patient with severe burn and trauma in the lesion is shown is consistent with stress ulcers, B, Cushing's, letter C, curling, letter D, decubitus. So you see all these are ulcers. Ulcers related to burns.
Stress. Burnout. Joke lang ha. Curly.
Okay, so a recall question that needs to
Uy,
be
di naman namin
memorized,
nung
but
sagot
you
na
have to be helped with the memorization here. This is an example of acute ulcers of the stomach, and you have a lot of causes. You can have drug-induced, you can have relation to severe trauma and burn. If it is related to burn, it is a curling ulcer. Lang yun. Burn, curl. Anything with R. If it is related with CNS,
Burn, curl. May curling iron na lang.
like craniotomy, it is Cushing, CNS, Cushing's ulcer. Okay? So that's the what to make it to help. Stress ulcers are usually seen in anxiety reaction and in shock state. Yes, shock. Stress. Okay. Decubitus, forget it. It's an ulcer in the back of your gluteal area. So that's not an ulcer in the stomach. Okay? So there. So that makes your life easier. Okay, next.
Accident. Trauma.
The next question is, the depicted lesion is consistent with the diagnosis of, is it Linitis plastica, B,
Rhinitis.
gastric carcinoma,
Rhinitis.
C, gastric carcinoid, letter D, GIST.
Dynasty. A yan.
Dali lang yan.
Water bottle.
Very good. Linitis plastica. It looks like a leather bottle. Okay? Linitis plastica is leather bottle. And Linitis plastica is a form of diffusely infiltrating carcinoma of the stomach, which is very aggressive. Once you have it, in 6 months' time, you're almost dead. And microscopically, you usually see a signet ring type of lesions. This is the signet ring. No? So, Linitis plastica is associated, this is the type, leather bottle appearance is associated with Linitis plastica, which is a very aggressive gastric form of carcinoma. Gastric lymphoma is a tumor of lymphoid origin, used as originating from mucosa-associated lymphoid tissue, or MALT. Or sometimes we call this maltoma. Lymphoma of the extranodal mucosa-associated lymphoid tissue, usually B-cell in origin. This does not look like an immature lymphocyte. Gastric carcinoid is a neuroendocrine tumor, which is not what we see here, and it is a carcinoid associated with carcinoid syndrome, wherein they elaborate, these tumors elaborate vasoactive amine, like serotonin and histamine. And GIST is a gastrointestinal stromal tumor originating from mesenchymal cells of the interstitial cell of Cajal. So the correct answer here is Linitis plastica. Next slide. The 25-year-old presents with jaundice, fever, right upper